So I'm going to do a Myeloma 101. For myelomas, the second most common blood cancer, lymphoma is the most common blood cancer. 30,000 cases are diagnosed in 2007, and 103 are living with myeloma or in remission, and we'll talk about that in a second. It's 2% of all cancers, and it is a disease of full adults. So if you are 30 and younger, you're a kid. If you're 30 to 65, you're an adult. And if you're 65, you are a true adult. If you're 102, then you are, anyone 102? Then you're old. Shouldn't have said that. The average age is about 70, and it is more common in men than in women. So what are the symptoms of myeloma? Well, because myeloma grows inside the bone marrow, you can get lower blood counts, and that happens in 60% of patients, and that causes weakness and fatigue. Also, the protein can get caught in the kidney, causing kidney problems, which can cause weakness. It can cause bone damage, and 85% of myeloma patients will have some bone lesions, and that can lead to fractures and bone pain. And then when the plasma cells move from the bone marrow into the bone, it can eat away at the bone, and the bone damage, but also release calcium, cause loss of appetite. About 10 to 20% of patients will have no symptoms at all and will be diagnosed via the suspicion of your doctor, or that you bring up that I feel really tired, I'm 65, could I have myeloma? So the beginning of myeloma begins with monoclonal gammopathy of uncertain significance. There are a lot of people that have that. They usually have a low protein, low plasma cells, really very early, a low amount of disease. It has a low risk of turning into myeloma. If you develop more plasma cells and the mutations get worse, it can cause smoldering myeloma. Protein goes up, the number of plasma cells goes up. But again, there are no symptoms at the time of discovery. And that to multiple myeloma. In multiple myeloma, you need a biopsy of something. You have to prove that there are mutant plasma cells in your body. Most times it's a bone marrow biopsy. And you need one of the CRAB criteria, one of these signs of myeloma, either high calcium, kidney problems, anemia, or low red blood count, or a bone lesion, or a hole in the bone, lytic lesion, seen on one of the imaging tests. We now consider that people that have asymptomatic myeloma, if they have the clonal plasma cells greater than 60% in the bone marrow, or if they have a lot of free light chains, or on the super sensitive test, the MRI, if they have more than one MRI lesions, basically, for those high-risk smoldering patients, it's about an 80 to 90% likelihood that they'll become symptomatic in the next few years, so we consider treatment in those patients also. So it is important to know what labs to check and what labs are followed when you have myeloma. You know, there's a red blood cell and comprehensive panel that are pretty standard, looking at the CBC, looking at the red blood cells, white cells, the comprehensive panel looking at the calcium and albumin and creatinine, you know, the things that can be altered with myeloma. The beta-2 microglobulin is really specific for multiple myeloma, and the beta-2 is on the plasma cells, and they are pushed out of the bone marrow, and they're metabolized by the kidney, and so they're used for staging, how many plasma cells you have, and if you have any kidney damage. The LDH, not the LDL, that's the cholesterol level. The LDH is a chemical that's released when the plasma cells are dividing, so any cells that are dividing, it can release LDH, so it tells you how fast things are growing with the myeloma. Of course, the higher those numbers are, the higher the kinetic, or sometimes the aggressiveness of the disease. And then there, in yellow, I put the really important tests, which are the ways that we see how much myeloma you have. There's a protein electrophoresis that we'll talk about, the immunofixation, the light chains, the urine test. We'll talk about all those in a second, but those are the ways to know. You come in and the myelomas appear, the protein's high, and then these tests should go down when you're treated, and you know if you're relapsed if they start going up again. So about 80% of patients, just like we've seen, have a monoclonal protein with an IgG and a little bit of kappa or lambda. 20% have light chain only, where you have to use a serum you have to use the light chain test or the urine test. And then there are 3 to 4% of people who their myeloma has enough mutations where they can't make any protein. And then we have to do things like bone marrow biopsies and x-rays to find out how they're doing. Speaking of x-rays, we used to use almost exclusively x-rays, just plain x-rays. X-rays are 118-year-old technology, therefore it's not very sensitive. We now use a lot of MRIs, CT scans, and PET scans in order to figure out where the disease is in the bone. And those are 85% more sensitive than the x-ray test. The other way to know how the myeloma is doing is to do a bone marrow biopsy. Anybody seen that before? And so it's really, really an important test because it tells us the mutations that cause the myeloma in the first place. And we use the FISH test in order to see which chromosomes or which mutations happen in the plasma cell. And that's a really important test because it tells us what the mutations are. These mutations are only in the plasma cells. They're not in the rest of your body. And you have one chromosome from mom, one chromosome from dad, and that's the normal plasma cell, is that you have 2 copies of each chromosome. And they stay apart and they do their own thing. If you have myeloma, you could have the 4th and 14th chromosome from mom and from dad sitting around, but the mutation occurs when those 2 get stuck together, and that causes problems and causes the cells to grow out of control, which causes the cancer. There are a lot of patients that will have, with myeloma, that will have 3 copies of chromosomes or genes that cause the mutation, which causes the myeloma. So it's really important to know that. We also, and I'll show you in a second why, because it has to deal with staging. And we do, right now we're doing the FISH test and to see what the mutations are. We now are using genomic testing to see exactly pinpoint the number of mutations. The FISH test looks at about 14 different mutations. The genomic testing looks at thousands of different mutations, so it has a much higher sensitivity and specificity for the mutations. Why is all this important? Well, the people that we really worry about are the people that we recommend clinical trials for are the high-risk patients. That myeloma is more difficult to treat because the cells mutate on their own pretty rapidly. The intermediate risk factors are the 414 translocation that I mentioned. Sometimes chromosome 1 mutations are in there and deletion on the regular cytogenetic test of chromosome 13. And the standard risk, which most patients have, are the triplet chromosomes called hyperdiploid or 1114. And I'll show you why that is very interesting later today, and 614. But in the same way that if you do my genetic profiling, you would say that I should have hair. And I used to have hair, and my genes say that I should. But I don't. Why don't I? Is because the gene expression is really important too. And so if you have deletion of 17p or 414, does that mean that those genes are being expressed? It doesn't necessarily mean the genes are being expressed. And that's why we need better ways to classify myeloma, because if you have a bad or high-risk cytogenetic lesion, it doesn't necessarily mean that it's actually bad. We have to figure things out along the way. So the reason that that's important and the blood tests are important is that's how the staging system works. Then this is a new staging system, and it is important to know the staging system because there have been studies that have shown that patients who know their stage are more likely to participate in the decision-making of their disease in myeloma. So it's important, and the conversation you have with your doctor is important. And so knowing your stage helps you communicate and shows your doctor that you're empowered and you want to participate in the decision making. If you have a high LDH, remember that's when the cells reproduce rapidly, or high-risk cytogenetics that we talked about, that the high-risk mutations and a lot of plasma cells, the beta 2 is really high, then that means you have stage 3. Stage 1 is when the LDH is normal, the cells aren't dividing so rapidly, and the high-risk cytogenetics are absent. And so, again, it's important to know your stage in order to have conversations with your doctor. And it's really easy. If you don't know your stage, ask your doctor, what's my stage of the revised system, with the revised system. The COMPASS study has been fantastic, and we're trying to, again, find more specific mutations in myeloma to see exactly, when I said that I have genes for hair, but they're not being expressed, this is looking at very specific mutations for myeloma to update the risk classification. And I would also say to you that coming on the 23rd, there will be a webinar on the COMPASS study. So putting all those results together, the x-rays, the blood tests and urine tests, the bone marrow biopsy and the mutation testing, that gives the stage and prognosis, which is really important to know. So after having a diagnosis of myeloma, what is important for you to know? And I think that a lot of my patients know that I've been giving out recently a paper that has these points on it, because it's really important to know these things. And I would encourage you to talk to your doctor if you don't know these things yet. So what myeloma diagnosis? You should have a little folder or on a computer or iPad what your diagnosis is, and to have the actual copy of the report with you. Anywhere you go for a second opinion, if you go to Hawaii or Belize, that you have your diagnosis on a piece of paper. What's your risk and stage? And so the risk via the FISH testing, your stage by the revised testing, again, that helps you communicate with your doctor and understand about clinical trials and what you need. Also, how to read your M protein. And I think this is critical because the more plasma cells you have, the higher the protein or light chains there are. And it's important to know that if you are in a complete response or a very good partial response, that's a time to celebrate, that you have less protein and less myeloma, or even those may be below the level of detection. And also it empowers you to know if your protein is going up, that we need to make decisions about what to do at relapse. And know the side effects. We know that 38% of patients with myeloma do not discuss the side effects that they're having because of their drugs. The number one reason is that they feel that their doctor wouldn't understand. With myeloma doctors, that's all I do, is talk about side effects of medication. So it's really important. We know about side effects, and we have so many options now of how to work with them. Also, patients don't think that we have any options, so they don't talk to us because they think we have no options for the side effects. And we know more and more about how to treat the side effects for the myeloma treatment because we've been using these treatments for a good amount of time. Know who's on your care team. Know who you're going to call. It's really important to know if you have side effects, who are you going to call? You're not going to call Ghostbusters. You're going to call, you're going to call the nurse or the doctor or the nurse practitioner or a physician assistant to say, I'm having problems. And it's important to have a voice in that. And know where to obtain a second opinion. That you should never be afraid to ask for a second opinion from your doctor. It is really important to get a second opinion because myeloma is changing fast and furious for good reasons, and sometimes community physicians won't know about a lot of those changes. So I would strongly recommend getting a second opinion. I send second opinions to Jeff, and he sends second opinions to me in order to get a different view of things and suggestions. And then finally, always consider clinical trials. There are now a plethora of clinical trials at all stages of the disease. And so it is now a prime time to get involved in clinical trials and ask your doctor or ask the person who gave you a second opinion about clinical trials. So now when we diagnose someone with MGUS, again, a low risk of turning into myeloma, we don't treat for those. And we'll be talking about the treatment for smoldering myeloma, active myeloma. And we usually don't treat smoldering myeloma because not everyone develops myeloma, and so those patients are now put on clinical trials or observation. And there's lots of new stuff that's been happening in myeloma just recently. So when I had hair, a high top fade, and when I had cool shoes, that was a long time ago. We were using chemotherapy to treat myeloma. We don't use chemotherapy anymore. We use targeted, directed therapy for myeloma, including the newest drugs, Marrow, Implicity, and Darzalex. And there are more on the way. This is a new age in myeloma, where now we're using the immune system to attack myeloma. So this is my favorite slide. With the new biology of myeloma that we know, the response rates are now almost 100%. When patients get diagnosed, that we have very good options. We have had 5 drugs approved in myeloma since 2015, and there are now 3 new classes of drugs that have come out. And compared to other cancers, myeloma has had 13 times the number of approvals as compared to your average cancer. Things like pancreatic cancer still haven't had a drug approved in 30 years. And if you look at the number of patients that have been living with myeloma, in 2004 there were only 54,000. By 2011 it was 74,000. Why did the number of myeloma patients go up? Why did 19,000 people survive the disease between 2004 and 2011? Is the new technology that we use to treat myeloma. And today, as I said at the beginning of my clinical trial, of my talk, that now we have 103,000. So we went from 47,000 to 103,000 because of the advances in myeloma. And the biggest news, or big news, that just happened on Monday is we got another set of drugs that were approved for newly diagnosed myeloma, including the Immunotherapies we'll talk about in a bit. I mean, that is awesome. I've never seen this. All the other cancer doctors are jealous because I dress nice, and I'm knowledgeable about Star Wars, and because all the novel therapies. So now the survival is increasing and increasing. Myeloma is not curable yet, but it is survivable now. So thank you very much.
How does a patient know which of they said specifically 10 types of myeloma they fall into?
That's a very, very good question. So those 10 types can be, so you can look at the macroscopic level. The big picture is that patients can have, their plasma cells can produce different proteins. So IgG kappa, IgG lambda, IgA kappa, IgA lambda, light chain, kappa or lambda, or nothing at all. So you can look at the macroscopic level and say, yeah, the type of myeloma that you're going to follow the protein with can be one of those things. You fall a little bit lower, you can, a little bit closer, a little bit more microscopic, you can divide myeloma up by the different types of cytogenetic abnormalities and mutations, high risk, intermediate risk, and standard risk. And then if you go down to what the COMPASS study is trying to achieve, it seems like it might be, and again the data is early, that there may be 12 different types of myeloma at the microscopic genetic level based on the mutations that are found via the COMPASS study.
And then we have time for one more question. How soon do you think a blood test biopsy will replace a bone marrow biopsy in the diagnosis of myeloma?
Okay. So I think that is fantastic. I mean, that is actually being worked on and is getting closer. The technology needs to come up a little bit because what the liquid biopsies are basically looking at looking at the mutations. The cells that are in your bone marrow and the plasma cells have very specific mutations. Some of that DNA floats through your blood, and they can find that DNA, read that DNA, and say this is from a plasma cell and has the following mutations. So that is being worked on. We've been using bone marrow biopsies again for 174 years to figure out, to diagnose myeloma, and that day is coming to an end.
You have energy for one more question?
Sure.
All right, one more.
I'm young, man. I got energy to spare.
Younger than me. Is staging still relevant after a patient has had therapy?
So staging, we usually don't use staging further. So there are cancers that restage after therapy. There is a separate system that we use to say the degree of response. So it is, if you have no change in your myeloma protein, then that's called stable disease. If you've lost half of your protein, half of your myeloma has decreased, then that's called a partial remission. Further down, if you have a 90% drop, that's called a very good partial response. And then if the protein zeroes out and there's no protein detected by the lab test, that's called a complete response. So there is a separate staging system based on response. And when the disease comes back, sometimes we repeat the bone marrow biopsy, and people can be classified as having a high-risk relapse, a intermediate or low or standard risk relapse, and so, or that the mutations haven't changed too much from the time of diagnosis. So, but we don't use the original staging system again throughout someone's disease.
Right, and I think that's an important point. I think many of us in the field and patients who know other people with cancer, we use the word restaging your myeloma as sort of interchangeably with reassessing your myeloma. Mm-hmm. And when we say, we got to restage things seem to be changing, really what we're talking about is taking stock of where things are at right at that moment. Staging, if we're using correct terminology, is something that you are assigned at the time of your diagnosis, and it predicts your prognosis to some degree from the time of diagnosis, but over the course of one's disease, we don't look at your beta-2 microglobulin, for instance, and say, well, now you're stage 3. No, I mean, if your stage is whatever your stage was when you were first diagnosed.